My name is Kofi Effah. I am a gynecologist and the head of the Cervical Cancer Prevention and Training Center in Catholic Hospital, Battor. Cervical cancer continues to kill women in Ghana. The statistics show that every year over 3,000 women are diagnosed with cervical cancer in Ghana, and over 2,000 women die from the disease. This is regrettable because cervical cancer is a very preventable disease which is preceded by a long period, many years of pre-cancer, which can be picked up, detected, and then treated so that cancer does not develop. So it is really sad if we have a woman in this country developing cervical cancer. There are many ways we can prevent cervical cancer. Some countries have gone ahead to roll out national vaccination programs for boys and girls 9 to 14-year-olds, and the aim is for them not to get the human papillomavirus, the virus that causes cervical cancer. This is possible, and I think that it is an area Ghana has to invest in. So that is primary prevention. When we talk about primary prevention, we are talking about lifestyle modification. We need to modify our lifestyle, especially sexual lifestyle, because the human papillomavirus, the group of viruses that cause cervical cancer, this group of viruses is mainly sexually transmitted. So human papillomavirus transmission goes to lifestyle modification. Preventing it goes to lifestyle modification, especially sexual lifestyle modification. Then we also have vaccination as primary prevention, and we recommend that boys and girls 9 to 14 years old get vaccinated. There are people who ask, why should boys also be vaccinated? The point is that the human papillomavirus, the high-risk human papillomavirus, does not cause only cervical cancer. In women, it can cause vulval cancer, it can cause vaginal cancers, and it can cause anal cancers, as well as oropharyngeal or throat cancers in women. And in males, it can cause penile cancer, anal cancer, and oropharyngeal or throat cancers. So boys also benefit from vaccination in the sense that they get protected themselves when they are vaccinated against with the human papillomavirus vaccine. They get protection against these cancers I mentioned. Then the other thing is that if they get protection and they do not acquire the virus, then there's something called herd immunity. They also get protection for women because they do not transmit the human papillomavirus to women to make them get the cervical cancer. So boys protect themselves and protect girls or women also when they get vaccinated. The human papillomavirus infection, I usually refer to it as a chicken and egg situation. We can't tell whether the chicken and egg, which came first. Is it the chicken that laid the egg, or the egg that had the chicken? So is it the man that gave the human papillomavirus to the woman, or the woman that gave it to the man? It goes many ways. You can't tell who actually gave it to whom. But boys can also get human papillomavirus infection. Girls can get human papillomavirus. Then mainly it is through skin contact, skin or mucous membrane contact. So, and most of the time it is through sexual means. So when a man or a male has sex with a female, then the penis, the human papillomavirus may be on the penis without the person being aware of it, or it may be in the vagina without the woman being aware of it, or on the cervix, and then the woman can give it to the man and the man can give it to the woman. Yes, so mainly it is sexually transmitted. It can stay for many years. There's a latent period for many years, 10 to 15 years before it develops into cervical cancer, sometimes up to 20 years before it develops into cervical cancer. And that is what makes it sad, because during these years, there may be changes on the cervix that can be picked up and then treated so that the woman does not develop cervical cancer. You see, the difference between cervical cancer and breast cancer is that breast cancer does not have a long latency period like cervical cancer. When a woman feels a lump in the breast, already it may be breast cancer. We want to pick the lump early so that it can be treated early. We can preserve the breast, but it already is cancer. But for cervical cancer, there's a long period where this is not cancer. We call it pre-cancer. And for 10 to 15 years, sometimes up to 20 years, we can pick this and treat before it develops into cancer. The interesting thing is that during this precancerous stage, the woman has no symptoms. There's no bleeding, there's no vaginal discharge. So the moment you get these symptoms, bleeding, vaginal discharge, already cancer, and you've missed the boat. But for this precancerous stage, the woman has no symptoms, and that is what gives a false sense of security. So women think that I don't have a discharge, I'm not bleeding, so I'm not at risk. That is not true. There are many women who have the virus and have had it for maybe 10 years, 15 years, and are on the verge of getting cervical cancer but have no idea. So that is why we recommend screening and treatment of the precancerous lesions so that they do not progress to cancer. And that is secondary prevention. I talked earlier about primary prevention, which is lifestyle modification and then vaccination. Secondary prevention involves screening to detect the precancerous lesions and then treating the precancerous lesions so that they do not develop into cancer. If there's one thing that has to be done, it must be prevention and primary prevention. Vaccination would be, I have to put my money on one thing, it will be vaccination. It may take 20 years to get the results, but the result would be clear and big compared to other means of intervention. Yes, there are already women who have missed the boat. They were not vaccinated 20 years ago, 30 years ago. So for those women, they will still need to be screened, and if they have lesions on the cervix, precancerous lesions, treated. That is where we come in here also. We realized some years ago, this center, the Cervical Cancer Prevention and Training Center in Catholic Hospital, Battor, was established in 2017. Before then, we were screening, but not in this center. We realized that it is one thing to talk about prevention, and another thing, being equipped on the ground to screen and treat. We realize our training institutions, though theoretically, our nurses, our midwives, our doctors are taught about cervical cancer prevention, it is more theoretical. So most of them leave their institutions and come out without practical skills to screen for and treat precancerous lesions of the cervix. So that is why this center was set up. We invested in training health workers to be able, especially middle cadre staff, midwives, general nurses, community health nurses. We train them to be able to screen and treat the precancerous lesions of the cervix. So if there's another area to invest in, it is to be able to screen and then treat the precancerous lesions of the cervix. Because if you cannot do that, then you cannot help the women. So for example, yes, I am advocating, for example, that the National Health Insurance Scheme should cover cervical precancer screening. It should cover it. Currently, it does not. I am advocating that it covers it. But we must first learn how to walk before we learn how to run. If you are not careful, we are going to get a situation where many women are screened across the country, they are positive, and then we do not have the human capacity to manage the screen positives. It has happened in other countries, So as we work towards getting a national health insurance scheme covering screening and treatment of precancer, cervical precancer, we should use this time to train health workers across the country to be able to do that. And we've been fortunate to be able to do this. Since September 2017, we've trained about 258 health workers across all 16 regions of the country. We need to do more. Not only that, we must equip them with skills and the devices to be able to treat the precancerous lesions of the cervix. That is where the challenge is. So we have two models here in our center. Model 1 trains these health workers to be able to set up and screen for the precancerous lesions of the cervix. Then Model 2 equips them with the skills to be able to treat the precancerous lesions of the cervix. We have very strict criteria to be able to come for the training. For example, people will then come and just acquire skills and be sitting in their institutions. So we insist that before you come for Model 2, your institution or you yourself, if you have an NGO, for example, should be able to you should have the device to treat the precancerous lesion of the cervix. Otherwise, then it's a theoretical course, and many people would like to come and then later come for refresher courses because we are already overwhelmed. Currently, there are less than 25 centers across the country where we can have this treatment of the precancerous lesions of the cervix. We've trained a few of them. The challenge has been getting the institutions to invest in purchasing these devices, cryotherapy units, thermal coagulators, which is surprising because a thermal coagulator, for example, costs just $1,500. It's just because if you compare in the past what was used for treatment, the cryotherapy unit is much more expensive. So $1,500 should not be something that should stand in the way of preventing cancer for our women in the country. So that is sad that we cannot get. I think that every district in this country should be able to have at least one center that screens and treats cervical precancer. Then we'll be on our way to embracing a national cervical cancer program that is covered by the National Health Insurance Scheme. If we don't do that, what will happen is that we will get women screened and they have to travel long distances for follow-up and treatment, and it can be frustrating. There are many districts in Ghana that do not have the ability to even screen. They do not have cervical precancer screening centers, and they do not have treatment centers for cervical precancer. So we have to invest in that. Otherwise, we would not be ready to have a national program for cervical cancer prevention. So that is very important. There's something interesting I would like to talk about. We did an analysis and found out that many times we have politicians, philanthropists, celebrities who would go out and then decide to screen 100, 200, 300 women in a one-time screening program. And after that, that is the end of it. We found out that the cost of screening 100 women in a one-time program is just about the cost of training a health worker in Model 1 of our training program. So our recommendation was that instead of investing money in a one-time program, you could channel that amount into training health workers in these districts we talk about. If, for example, each member of parliament would train one healthcare personnel in their district, we are going to have all 260 or so districts having health workers trained to offer cervical screening to prevent cervical cancer. But you know, in our setting, people usually want to be remembered for a big program they did. Then they are pointed at, you know, people, they take credit. People remember them for a big screening program they did. But when we talk about sustainability, it may be better if we invested these energies, monies into training people to work in the districts. So we will recommend that philanthropists should pick health workers to be trained to offer, and they can offer the service in the district sustainably 10 years, 20 years, even when they retire, they can still continue to screen and treat precancerous lesions of the cervix. Cervical cancer is preventable. If we invest in vaccination for boys and girls, if we invest in screening and treatment of cervical precancer, which we can do through the National Health Insurance Scheme, we will be able to reach out to many women in the country and prevent cervical cancer, because many women are not getting screened because they cannot afford to pay out of pocket. And making sure that the National Health Insurance Scheme covers it will bring cervical pre-cancer screening services to the doorsteps of women and prevent a lot of cancers.
It's a rare PCR machine, and then we use it for 8 and we can do other tests. Yeah, but we mainly use it for 8 So we can run 96 samples at a time. Within 2 hours, you can get your results.
We would like to show how current technology has changed the way we do things with cervical precancer screening and treatment of precancer. In the past, this is what we call a colposcope. This was the stationary, it's a stationary colposcope, the traditional colposcope that doctors used. It is heavy, it's difficult to carry it across the river or into the community. So women had to travel long distances to central points. So screening was centralized. People had to travel to come in. But times have changed, and now we have a mobile colposcope. So with this mobile colposcope in this box, they can actually carry a box and do about the same thing that we did in the past with the stationary colposcope. That is the first thing. And there's also treatment of precancer, cervical precancer. In the past, we had this cryotherapy unit, and you can see this is a cylinder that contains carbon dioxide. So we connect a tube to this, and then the tip will freeze, and then we'll freeze the cervical precancer on the cervix, the precancer on the cervix, we'll freeze it. It took about 16 minutes for treatment. You freeze for 3 minutes, you thaw for 5 minutes, you freeze for another 3 minutes, you thaw for 5 minutes. So 16 minutes. And you can imagine carrying this into the communities was difficult. We did it, but it was difficult. These days, we have a thermal coagulator, and Comfort, you can tell them about the thermal coagulator.
So these days we have a mobile device, a thermal coagulator, of course, which uses only 45 seconds to treat a precancerous lesion on a client, unlike using 16 minutes to treat with the cryo machine. This one uses only 45 seconds, and it's easy to carry this one across to a remote area or hard to reach area to treat a precancerous lesion on the cervix.
So it comes with a battery, which which is, in fact, we have 2 batteries. You can
chargeable battery. We have a system. We have 2 chargeable batteries and a probe that we fix together, and then the charger to charge the system.
So with these 2 boxes, the mobile colposcope, which they can carry like school bags, with these 2, these women are actually like mobile hospitals or mobile clinics. They can actually move from community to community, screening and treating cervical precancer. There are some of the lesions, the precancerous lesions, that we cannot treat with thermal coagulation. We use what we call a loop electrosurgical excision procedure, or LEEP. And it involves using a wire connected to a machine, you connect. So this is, say, a wire. You connect it to the diathermy machine, and then with electricity to it, it's hot. But the woman is, you give some form of anesthesia on the cervix, so the woman does not feel any pain, and then you treat it. So in the past, this is what we used. This is the diathermy machine, and we used it together with this smoke evacuator, a suction machine, because as you do the procedure, there will be smoke, and it can blind you if you don't suck the smoke off. So we did that with the smoke evacuator. So you can imagine, it was portable. It's still portable. You can carry this, and we sent it to many communities. We sent it out to do it. In fact, we actually went to Nsawam prison to screen 89 women in 2019, and we treated 2 of them with this there in the theater in Nsawam without them having to come out. So that is how possible portable machines are. But even this has been made more portable, easier to use, because now you can have this same thing. These 2 things have been compressed into one. A company in the US has made this portable. So it's a diathermy machine, and at the same time, it also has the smoke evacuator. It has the power to suction the smoke, to suck out the smoke, so that you don't get blind, as like I mentioned earlier. So it is also, you have a battery in here. Yes. So it's a battery. It comes with 2 batteries which you can connect. You charge and connect. So when you go out, you don't need electricity, because you are prepared and you can treat many women without having even electricity. So that is how current technologies have shaped our way of cervical cancer prevention. And if institutions would come along with current technologies, it is possible to reach out to the most difficult to reach areas in the country or in the world to prevent cervical cancer. Our women deserve this, and it is possible now.